think that they basically work as they're sort of an orthogonal tracks because they don't really run anterior posterior. They cross the systems, and they're the only exceptions to the system rule. And then you have the medial systems, the cingulum, the fornix, and the corpus callosum, and I'll show you the relationships. And then everything between them is the motor system and the thalamic peduncles. So again, you can see the frontal ascending tract. It basically is hooking from the SMA to Broca's area. I became familiar with this tract several years ago and began putting it on my image guidance system. And I have some very interesting data, which we're currently under review. But again, no one knew about this tract until about 2010. So partly because until you have this kind of resolution, multi-directional tensor tractography, it's impossible to see it. It blends in with a much bigger tract of the SLF. We mapped this out, and one of the things that immediately struck us is, what is this connecting? So I know everyone doesn't know the nomenclature, so let me run through it real quick. That green one is superior frontal language area, and it's going to areas part of the canonical Broca's area. Like, for example, FOP4 is the frontal operculum part 4, and it's joined up with area 44. You have here, this is the motor part S6MA. It's a motor part of the supplementary motor area. So it came to our idea that given the supplementary motor area was a motor and usually a mutism problem, that this probably had something.
Oh.
So we began looking at this and saying, okay, let's not cut that. So when we looked at this, we this is on the left is before I learned about this track. And on the right, this is when I knew about the track, had it on my tractography, and made an effort to not cut it. Now, I don't know for sure I cut it every time before or that I never cut it after. But basically, once we were aware of the tract and stopped hitting it, we stopped having SMA syndrome. As simple as that. So it's probably a preventable problem. And I can show you some fascinating cases where the SMA does not need to talk to the motor cortex in order to work. It needs to talk to the FAT and the basal ganglia. So if you respect that axis, people are able to basically not develop SMA syndrome. And so then the question is, how important is it to avoid SMA syndrome? And I would say in general, it's probably a good idea to avoid it if possible. You can see this is the canonical SMA, and we've mapped who basically is part of that. Now, when you look at the motor systems, the premotor systems, it's important to note that we spent a lot of time trying to avoid the motor cortex, but we haven't really thought what would happen if there is nothing connected to the motor cortex. Well, of course, you'd be paralyzed, right? You have to have something driving the motor cortex. And actually, there's an entire system of areas other than the SMA that are part of some aspect of motor control. Now, the question is how expendable are they, and exactly how important it is, and how often do we destroy them? This is a question for the future. But one of the things I want to really draw everyone on is the fact that you have this area 55B. This was discovered and really highlighted in the Human Connectome Project, but we've gone a lot further in this. And 55B is probably the motor cortex for the larynx. And so we have cases of people that we found where we violated 55B unknowingly before we knew that this area existed. And it has its own connections to some of the Wernicke type areas. We found that those patients can have often normal speech other than the fact that they cannot phonate. They can't use their larynx or create normal sounds. And so it is a language or speech area, is a better way to put it, inside the precentral sulcus, away from Broca's area. And this is a new finding. So you can see we've highlighted the anatomy of the motor system. The key thing about operating around the motor system is that it's a bouquet of flowers. You need to respect the bouquet by making coronal cuts that do not disconnect areas like this with this as much as possible. You can see the ventral premotor system of how extensively interconnected these areas are. And I think that we need to really start to look more into the concept that just because someone can move an arm doesn't mean it's useful to them. We need to have motor control with sensory and haptic feedback. You need to have motor control with eccentric control, otherwise your arm will flop on the ground. So just because a patient's moving all forward doesn't mean they're normal. And we need to really start to think about this a little bit more sophisticated than just don't cut the corticospinal tract or the motor cortex. Now, moving on to the superior longitudinal fasciculus. This is a dissection. This is actually the first time I ever dissected this out many years ago. And I took this picture because it just shocked me how big. This is actually about half of the SLF here. And you can see it's much bigger than the optic nerve. It's much bigger than the spinal cord. It's connecting a large number of highly important cognitive areas, yet we treat it like it doesn't exist, or we have in the past. And it's really shocked me that I had probably cut this in people and not really been too concerned about it at the time. That this is much bigger than we think, but we just don't see it. So to look at the SLF, here's basically my schema for this. So it starts by these frontal rami that bend to not only Broca's area, but also areas in the inferior frontal sulcus, posterior medial frontal gyrus, middle frontal gyrus. Then there's this body. The body is running under the motor cortex. In part, this is important because even if a patient is hemiplegic, we've always thought that this gave somebody carte blanche to operate in the motor cortex. And that's true up until the bottom of the sulcus, at which point you could always make them worse by adding a SLF injury to their corticospinal injury. So it really is a highlight that there really isn't a situation where it's just truly possible to go crazy on a tumor without regard for what you could add on to the patient's disability. Now, there's a parietal ramus. This is going to the intraparietal sulcus. You can see that there's this genu here, and this goes down to the temporal stem, at which point it bends into two rami. One is the arcuate, and the other is what's called the SLF2. And these two areas, wherever this is going to be language 97% of the time, is going to be within about a centimeter of that area, wherever it is. And we have published that in neurosurgery several years ago. So I take wherever this stem is happening on the left side as a very good measure of language. So what do I mean? Okay, so this is a simple tractography with the Medtronic system. You can see here's the frontal rami, the body, there's the genu, and then right there's the stem. You're starting to see one of the bends, right? But here's where you're seeing this. That little stem, wherever this is going to be language. It's going to be wherever it's coming to the surface. And so you can't trust it millimetrically. It's not going to tell you exactly where it is, but it's crazy to make that entry point. Okay, so that's not really where you want to be. And so once I began doing awake speech mapping and mapping these areas, I found that this is a very, very important landmark to know. Not because it can tell you whether you can cut, it just tells you need to be careful where you're looking. Now this looks at it with diffusion spectrum image, or DSI. It's a much higher resolution, able to show angular crossing fibers. So you can see it has a much bigger, foliage. These white dots are everywhere that the tract is terminating or beginning. Actually, almost all these tracts are bidirectional, so we shouldn't be putting arrows on them. We don't. But what you can see here is just how many areas of the operculum and frontal lobe are connected. But also you see this sort of, in the back, you have this sort of dividing temporal rami. And this is going to be the language system or the neglect system. So I've shown this before. Again, I can't go into all of this. There's so many fascinating concepts in here. But one of the things that, again, combined with IFOF that this tract is doing is it's bracketing the insula. So if you're in the peripercular and insular area and you're trying to figure out where's the best place to go, well, the worst place to go is anywhere outside the insula. So believe it or not, the insula is the only safe area where you're probably not cutting across a tract when you're in this general area. They sort of form a wall. This is our map of language. Okay, now it's important to note that there should be a difference between speech and language. This is probably a better description of speech production and how semantic function, meaning the meaning of words. Semantics basically means the meaning, what words mean. How it gets to the language and speech processing areas. What's interesting is that there's a two-stream model, but it's not the streams that people have been talking about in recent years. It's a stream by which this area here connects to the 44 as does the SMA via the FAT to form a kind of canonical system. But then there's a second stream that goes to 55B. And these two areas don't talk to each other at all. They're separate streams. Now, the next question is, there's been a lot of discussion about what does the temporal pole do on the left side with regards to language, not speech production, language. This is a fascinating topic, and I'm not going to be able to answer this here. But we do know that if you do a temporal lobectomy, many patients have subtle language problems that are picked up on task, which are not as debilitating as, say, pure aphasia, but are certainly not trivial. And we know the most about this through the dementia literature, where the dementia literature has clearly shown that if you have what's called semantic dementia, where you basically have perfectly grammatic, syntactically correct speech that has devoid of meaningful content, that the lesion is here. What's interesting is that this is not part of any of the semantic tasks that we found in our meta-analysis. So nothing involving semantics goes on here primarily. But what's interesting is this area does have that. And it's basically connected by this band of functional connectivity. What we found that's going on underneath this is that there's a unique series of U fibers that are carrying this as a serial function between A and B. They're the only place in the brain that we have found where there's a series of U fibers which parallels the sulcus. It's very unique. And then this area here, of course, we know directly talks to this via the uncinate fasciculus. So there's a simple explanation there. What's fascinating about it also is that, and I know everyone who isn't an expert at this, but I'll just show you that this area, and this area are part of a network that I'm going to talk about in a second called the default mode network, which is actually a network that I've been fascinated with for a long time and have written about in other papers. So what shows is that language is probably, particularly higher level language, is a DMN function. What's also interesting that we found is that the auditory system, which is the superior temporal gyrus area, has its own connections to Broca's area outside of the language system. So it isn't so much that there's a Wernicke's area, it's that there's a series of two networks talking to each other in this vicinity that directly talk and converge on Broca's area. We've looked at praxis. This is the sites that are necessary for apraxia. Not surprisingly, they have a lot of the same areas of speech. But more importantly, again, what happens if you make that cut across the middle of the body of the SLF? It's not very good. Now, here's another fascinating one, which is what is neglect? How do you get neglect? Okay. Now, this is the areas that are lesioned in patients with neglect across studies. Okay, so we've combined them into 40 studies on this. And what you can see is that this is the SLF on the right side. So we didn't discover that. That has been known. But we started looking and saying, what about the areas that's joining? And this is where it gets really interesting. Okay, so this is a noisy diagram. I'm going to take you guys through it because it took me about 3 months to figure out, of staring at this, to figure out what it actually was. So we thought, well, what network is it going to be? It's got to be one of these networks. And turns out it's a little, this is the analog of language on the right side. That's the auditory network. This is the somatosensory network. These are the parietal areas that are a part of the executive network. This is part of the executive network. That's the frontal eye field. This is an attention network. That's olfactory cortex. So we looked at this and said, this doesn't make any sense. None of these things have anything to do with each other. And then it dawned on us that it wasn't the areas that were important. It's the fibers. What they're doing is they're linking up networks that have nothing to do with each other and causing all of the sensory modalities to talk to each other and bind into a single world, which is what we think neglect is. So neglect is a white matter injury. These areas can cause it too, but it's really predominantly a white matter problem. But the bottom line is the right SLF is important too. Now, there are two other attention networks. One is a bilateral network called the dorsal attention network. I don't think this is the correct name for this anymore. I think that the right name for this is a cognition network. And I don't have time to go into it right now, but we do know that the less of your DAN you have at the end of, say, a surgery or a stroke, the lower your IQ. And here, on the right side, there's a right-sided network called the VAN. We thought, well, this has to be the neglect network. But if you look, it's none of the areas that we're talking about for the most part. And we looked at the ALEs, and neither one of them were. So neglect is its own system. It's its own network. And it's not a, it's a really an internetwork. It's the white matter that joins networks up and causes you to have a single worldview. And that's our best theory of what the anatomy of neglect is. But the bottom line is don't cut the right SLF either. It's not a good idea no matter where you are. So you can see that inside the SLF arcuate, we have speech, praxis, neglect, the executive network, we'll talk about in a second, the two ventral and dorsal attention networks, and the even part of the visual system are in that network. So again, ignore it at your own risk. Next is IFOF. So IFOF is a very big tract. It fades out both in the frontal lobe and the occipital lobe. And it has this little area here running along the bottom of the insula. So here, not so important that you don't get into it. Here, not so important that you don't get into it. But between here and here, you can take the whole system down with one cut.
Da bench laga kwa ka na da bench laga kwa ka bench.
So between the in the insula, the key point is to stay inside the insula. Don't get too high, too low, too posterior. This is your only safe area. Now, the question is, what is it doing? And this is fascinating, okay? So when I was first introduced to this tract, the theory was that it was taking this visual information and sending it forward to the cognitive areas to act on. And this is my theory for years, until I actually had the map. Now that I have the map, I'm going to tell you that that can't possibly be true, because if you look at who these visual areas are, they're V1, V2, V3, V4. These are areas that are looking at which direction the line is going. These areas here are the dorsal visual stream. And if you know the dorsal visual stream, this is a where pathway. It only tells where things are. So why would the cognitive systems need this information to work with? What's more likely happening is that the cognitive systems are telling the visual system what to pay attention to. Okay, so it's really a frontal occipital, not an occipital frontal. Now, there could be some information going forward here. I may be wrong. But the answer is it's more likely that this system is telling this system what to do. But more importantly, it's not carrying primary, aggressively studied visual information forward. Those areas, for example, MT, MST, or some higher level visual recognition areas, the ones that are able to discriminate faces, none of those things connect through any of the tracks that we found. Another track that does something similar is the ILF, and what it's doing is basically it's the IFOF for the temporal lobe. So it goes from the temporal pole to the occipital pole, and the three, the IFOF, the arcuate SLF, and the ILF create a wall here that prevent you from really taking any safe path that goes straight from the side of the head into the deep structures. So your best routes to the deep structures surgically are this way and this way. Maybe this way if you could get a good angle, but these are the two best ways, meaning superior parietal lobule or transfrontal. And we've known this for decades, but now we have a clear understanding of why that is. And as you can see, that as a whole, the lateral system really makes it difficult to take a straight path into the insula, into the temporal area, the basal ganglia areas, the ventricle, etc. Now, again, the ILF is a little bit more complicated, and I know everyone doesn't know all these, but let me just kind of take everyone through a few things. So this area here at TGD is the temporal pole area. It's really the biggest and probably most important area. It's actually one of the most connected areas of the human brain. And what you can see here is it's connecting to some variety of different visual areas, but most of the visual areas are early visual areas. So there might be some information going from occipital to temporal. I think that in part, a lot of what these pathways are doing is it's the systems, the higher executive systems, the language system, talking back to the visual areas and telling them what to process and helping them process. And of course, the deepest part of the lateral system are the optic radiations. I think everyone knows this. It basically is going from the pulvinar and LGN backwards towards the early visual areas. And then for completeness, this is the unset fasciculus. The vast majority of it is going to this area TGD. Moving to the medial system, you have this format here. And this is something that took me a long time to really get a grasp on. And what it is the relationship between the corpus callosum and the cingulum. So the corpus callosum is mostly connecting homologous parts of the medial lobes. So for example, the superior frontal gyrus to the other superior frontal gyrus. There are some non-homologous connections where this connects, for example, to Broca's area. That does exist in most people. But the cingulate is a different system, it has different number of cortical layers, and it's not connected to this. So there really is only a few areas where the cingulum connects to anything else, and there's very little evidence that we've ever found that any part of the cingulate gyrus is sending anything through the corpus callosum. They really work separately. So again, the corpus callosum, you see that there's some areas here that are non-homologous, but most of it is connecting medial to medial. And this is why, for example, the superior parietal lobule is probably better tolerated, because there's just so many connections between the midline structures. The cingulum is basically kind of making a C shape like this, but of course it's bidirectional. When you go back though, it's important to note that we don't pay much attention to this little part of the brain. But this part of the brain is, and I'll just say it right now, is probably one of the most functionally and structurally connected parts of the human brain. So it's a critical part of cognition. And so we need to really start taking really a better stock of how important parts of the cingulate, but especially the posterior cingulate is, because we don't think very much about it, but it probably has cognitive consequences when we cut into it or a tumor is destroyed, et cetera. So again, if you look at this relationship, right, you have the cingulum running the sort of little tube, and those blue fibers are wrapping around it, almost like a surfer riding in a wave, like a little barrel wave. But you can see that for the most part, there's only two areas that send a significant number of fibers, the anterior portion and the posterior portion. After that, it's mostly just traveling along. And these two areas are the default mode network, and to a lesser extent, the salience network. So we know that when we see these fibers exiting the cingulum, they're going to the DMN. And I'll talk about that in a second. But again, this diagram should shock everyone. We've all heard the cingulum in medical school. I heard about it as a first-year student. But look at all the areas. This is what's going to the posterior cingulate. It's shocking. And the functional data also align with this. So it's not a trivial part of the brain. So going through the precuneus or going through the posterior cingulate on your way to a tumor, you should think twice about that. That's not really a shorter target in most people. So I've talked about the DMN, the control network. I think this is one of the ones that we as neurosurgeons need to work into our thinking process, because we consider these eloquent parts of the brain and rank them up there, particularly some of the DMN and salience areas, as important as the motor cortex, and probably in some people more important. So nobody really knew about these networks till probably less than a decade and a half ago, about 15 years ago. They were discovered in 2001 initially. And what they do is that they're controlling a series of networks. They sit at the top of a hierarchy where they control the function of other networks. And what they do is they figure out where's the brain going to allocate resources. Okay. They may not be doing this coherently, but this is what they functionally do. So when you're thinking to yourself, the default mode network, or DMN, is on. It's off anytime you're doing any task. And how they found this was when they were looking at fMRI studies, this was always on in the controls. So somebody followed this up and turned out it's one of the most important networks in the brain. This network, third network, the salience network, mediates the switch between the executive network and the DMN. And it's been shown by our group and other people that the failure of this system to work fluidly is synonymous with a depressed or altered level of consciousness in many people. So this is the DMN. It's a three-part network. You have this anterior cingulate, the posterior cingulate, and then there's a lateral posterior parietal. This is basically the angular gyrus. These two areas talk via the cingulum, these areas don't talk at all to this. This is fascinating. We don't totally understand this, but we've never found any evidence that these two parts of the network talk to each other, nor do we think that they do physically. And you can see we have a very detailed map of this. The salience network is a middle cingulate and anterior insula, and they connect by the FAT. In fact, everything in the FAT that's not connecting to the SMA to Broca's area is part of the salience network. There's almost nothing else we know of that's in this system. Now, the salience network is in charge of taking you from thinking to yourself or daydreaming to active thought. But it's also important for whether you determine to pay attention to pain. In fact, there's data suggesting that people who have fibromyalgia, one of their key problems is an abnormal salience network. We actually have started a clinic to shut down the salience network of chronic pain patients instead of giving them back surgeries that we don't think are going to help them. So this is obviously becoming a more important topic in this area. And I think that we really need to start paying a lot more attention to the salience network. And the executive network are areas that we typically think of as executive function. So it's the frontal pole, the prefrontal cortex, and the supramarginal gyrus. They talk to each other probably through both the IFOF and parts of the SLF, depending on the person. But we started studying these in combination. We started saying, how do these networks talk to each other? Because we were just interested in this because we think it's important. And this is a concept that I've come up with called the initiation axis. And I'll show you what I mean by this. But we think that it's necessary to get out of the neutral gear of mind wandering and to take action. And if you don't have the system, you're akinetic or abulic or some variation on this. So it works something like this. You have your default mode network, the salience network, and then there's the SMA. Now, if you think about the SMA, an SMA syndrome, supplementary motor area syndrome, is the inability to initiate motor movement or speech movement, okay? So having an SMA syndrome is basically an initiation problem, if you really get down to it. And it's interesting that the salience network and the SMA share one of their parcellations. They share one part right here. So this kind of, we thought this formed an axis. And what's interesting is that while there's this other lateral system here, which is a little bit more complicated, in fact, the control network and DMN talk to each other here, what we really think this highlights is the fact that bifrontal equals bi initiation axis. So a bifrontal patient, someone who has a bilateral ACA stroke, for example, has an injury to this bilaterally. We think there's a percentage of people who can tolerate a unilateral disruption, particularly if there's tumor there. But in general, we try to stay out of this or preserve as much of this as possible because we think this is important for having a quality of life. Being akinetic, mute, or abulic is not a quality of life that anyone would want. And I'll kind of zoom through some of this because, again, I can go on for a long time. But let's talk about what else we can do with this. So a lot of what we talked about is how do we explain clinical problems? How do we decide what not to cut? Well, these are critical questions in neurosurgery as our field. But the question is, well, how do we learn these new areas? And we know that patients are all different, and some people can have a lobectomy of the frontal lobe and be fine, and other people could take a temporal lobectomy and do terrible with it. Well, part of it is this. There's been a discussion out there, and even someone published a paper in JNS about a year ago now, talking about the idea that there is no such thing as eloquent cortex. I think that while that's a good spirit, because obviously I think that all parts of the brain are doing something, it of course doesn't line up with reality. We know we can cut into the brain. It's certain. So the question is, why could we ever do brain surgery? Why doesn't everyone have a neurologic deficit with all cuts? And the answer is redundancy. The network is complex, it is redundant, and has the ability to get a signal around a blockade in some cases. So the issue is right now, we can't make an educated guess on this. fMRI is not, by itself, is not able to do it. Just because an area is active doesn't mean it's essential. So this is what we're working on. So what you can do with connectomics is you can take all the brain and make it into a gigantic graph. So what this means is this is one parcellation in one area, and there's a line between A and B if there is connection. And you can even weight them where the thicker the bundle, the more number this has. Well, we've done a lot of studies with graphs like this, and there's a lot of interesting things. Most importantly, that if you look at graphs, you can measure what's called centrality, which is who is the hub, who does most of the information flow through. And what I'll tell you, and we've just submitted this paper, is that the areas with highest graph centrality are what neurosurgeons have long called eloquent cortex. They're the same areas. So there is really no area by itself that's always eloquent. It's any area with high centrality we should not violate. But what about the areas that have high centrality that we don't know what they're doing? Well, these may be the people who don't go back to work, patients who have cognitive problems, and it may also explain why some people we can be more aggressive with some tumors than others, especially in eloquent areas. But here's where it gets more interesting. Let's say we can sit down and delete parts of that graph. Well, deleting parts of that graph are surgery. That's what we do. We delete parts of a graph when you really get down to it mathematically. So what if we did that before we did the surgery? So this is what we're working on right now. So this is actually my brain. We've done DTIs on this, and we've figured out, made a graph of this that we feed into the computer. And the computer simulates a set of differential equations everywhere in the brain, and then it couples them. So this is what you can do with that. You can see this is all simulated data. Now, what we're working on now is getting an interface where a neurosurgeon can delete that, draw a little area, it takes that off the graph, and tells you how it's changed, how the functions of all the areas have changed. This is probably a much better idea than just saying stay out of Broca's area. And it's possible now. Here's another thing you can do with connectomes. You can start looking at when a patient has a neurologic deficit, can we do something to get rid of it? And this isn't something that we're actively treating patients with right now. So this is the kind of stuff that comes off our scanner. But there's a lot you can do with it. And we've worked to create software that can handle this. So instead of just giving you this, it extracts the signal, the bold signal, at every single voxel in the brain. This is actually, again, my brain. You can see that these areas are obviously the Glasser parcellations that we've drawn. We have a machine learning model that will find all of these areas based on data. And we can basically just hit a button and say, show me the parcellations that we pulled out, and make something like this. This is obviously not my brain because there's a tumor there. But more interestingly, you can look at how each one of these areas talks. How often does it talk to other areas? And make something like this. So this is what's called the connectivity matrix. So this is how much every part of the brain talks to every other part of the brain. If they talk more than average, they're red. Less than average is blue. Now, just showing you this is not useful. But what's interesting is that you can teach machines to read this. And you can look at patients with depression or other illnesses. And depression has just been the most studied because it's extremely common and there's lots of research money for it. But what this group did is they showed that you can take that connectivity matrix and classify patients with depression into different groups. Now, so we know that if you give brain stimulation standard brain stimulation to patients with type 1, the response rate is 85%. If you give the type 4 the same treatment, 5% or less. So truthfully, depression is multiple different diseases. But more importantly, probably coma is more than multiple different diseases. Aphasia is multiple different diseases. And we really want to have better data sets for it. So again, what we're interested in doing is taking maps of the brain like this and giving it to people in the real world so that we can actually start to figure out what these things are and to help collect data. One thing you can do with this is what's called TMS. And this is some really exciting stuff. So I became familiar with TMS going to brain mapping meetings because obviously you do research on brain mapping. Some people are doing this. They tell you about it. I was just very surprised at when I learned about it. So how it works is that this coil has two wires that basically have electrical current going through them. And as we remember from physics, this makes a perpendicular magnetic current that goes into the brain, through the skull, and stimulates the brain. This is the amount of class 1 evidence in randomized sham-controlled trials of TMS for different diseases showing benefit. These are the level things that have a meta-analysis. There's 116 trials for depression, and now OCD. It's an FDA-approved treatment, and we know that the side effect profile of this is minimal. There's a tiny risk of a seizure. Otherwise, it never really makes people worse. And we also know from scientific data that it has the ability, done correctly, to induce brain plasticity changes that are often long-term. So we started getting the idea, well, what if somebody has a deficit in their connectome? Can we encourage the other pathways to take over and give them some function back? Given that there's such little risk, and we know this from class 1 evidence, we said, why not? And there's really not a good reason it hasn't been done in neurosurgery, just no one did. So this is the patient we treated. She came in aphasic, hemiperitic. This tumor was taken out. I did not do the surgery, but she, again, had pre-op deficits. In the past, we would have sent her to rehab and hoped we could make her better. But this is what we do instead. We take pictures of her networks. Now, what you're seeing here, this is the motor network on the left side or the right side. This is the motor network on the left side, the injured side. These are supposed to be one network. These are supposed to talk to each other, but they're not. They're not in the same network, okay? And you can also see that you have areas here that this is more disorganized. We've seen this over and over again in people with injured networks. So again, this is what we would like to do is say, it's trying to recruit this area to be part of this injured motor network. So we want to help that. Again, here's the language system. So, there's Broca's area, obviously. There's 55B. It's been there for years. We just didn't notice it. We didn't think about it, but it's always been there. And then you can see Wernicke's area is disorganized, right? Because these two areas, the tract is edematous and it's just not synchronized. But it's trying to recruit other areas. This is not supposed to be part of your language network. So there's another target. You can also shut down the good side. There are suppressive protocols. So we did that in her. You can see this is the patient. This is the coil. We basically map it. We put it on image guidance. Now, if you can hear that noise, every time it clicks, it's stimulating the brain 150 times. Okay? So it's a protocol called theta burst that you can deliver a lot of stimulation very quickly. And it takes about 10 minutes. That patient came in wheelchair bound, eventually could walk with a cane, regained quite a bit of her speech, and has some arm weakness. She's still weak in her arm. So we didn't make her perfect, but with that lesion, the fact that she's that functional is pretty impressive, I think. This is another case. You can see bad place to have a tumor. Now, this is anatomic and not radiologic. So this is left side on this image. Just, I apologize. That's just how the software renders it. Now, this guy's different. So his language system is robust, but it doesn't talk to itself because this is a white matter problem right here. So this doesn't talk to that. And he's recruiting the right side. So we don't want to suppress the right side. We want to stimulate here. So that's what we did. And you can see his motor system is totally absent on this side. Again, that was consistent with his clinical exam. So again, we've treated over 30 patients with this now. I don't think this is enough to say that this works. It just says that it's promising because, again, there's so many variables in here that depend, could these patients have improved on their own, et cetera, et cetera. This is not class 1 evidence. We're trying to say, most importantly, that it's a good idea and that it's safe. We have had no problems. We've had no one have a side effect for it. And so these are things that I think that connectomics can add to neurosurgery. I think it has the potential to completely revolutionize how we think about patients, how we do surgery, how we rehab patients afterwards, pretty much most aspects of what we do, because we really aren't going to progress further until we really harness and understand the complexity of the human brain. And we're not going to do that without computers and big data. If we were going to do that, we've had very good forefathers. They were very dedicated people, and they would have done it by now. So anyway, thanks, everyone.
Thank you, Mike. I was speaking with mute button on. Thanks for a great presentation. Okay, let's open it up right now for comments or questions from the panelists. If you have a question, just let me know. You unmute yourself and ask the question. Go ahead.
I see there's a question about on the thing about, can you talk about the connection between fMRI and dyslexia?
Well, Mike, I like working with you because you're pretty smart with the computer, and you spotted that before I did. Go ahead.
Yeah, so the answer is I'm not an expert at the data, so I don't want to go too far into the weeds here on it. But the answer to it is that as with many learning disabilities and most mental illnesses and numerous similar aspects, what people have found fundamentally that shows up over and over again is that areas of the brain that are supposed to be in sync with each other are often less in sync than normal. So it's not they don't talk to each other at all. There's not a track missing, for example. So if you look at ADHD, it's clear that there's a little network issue going on there. Now, what that is and how do we individualize it? It's a very complicated question. It's a huge area. My hunch, and again, I can't get too much into the dyslexia literature because, I just don't know it that well. But my hunch is that this has been studied and that it is almost certain that there's some form of asynchrony of some kind. And of course, then the question is why. We don't know.
Okay, I have a question, Mike. I'm not a neurosurgeon, but you've done a lot of glioma surgery. Did you get into studying connectomes after doing a lot of surgery, or is that something you've studied for a while?
Ultimately what happened was when I started in practice, I was a skull-based surgeon. But the first job that I took, I was the only person who did awake surgery in the state, and it was about 4 million people. So I did a lot of glioma surgery and a lot of awake glioma surgery. And one day I started doing tractography, and part of it was just almost as a gimmick. No one really told me how useful it was. And part of it, I put the arcuate fasciculus on there. This is many years ago now. And I was surprised at how accurate it was. And then I started saying, okay, well, I have this area. What do I not cut? What do I not do? I mean, I knew to some extent based on training with Mitch Berger and at UCSF and all this, but I felt like there were so many unanswered questions. And all I really wanted to do was have a model that I understood. And that just progressed and progressed and progressed to what you see now. It became really interesting because I started realizing how important the work that was being done by many very smart people and why it was important to get it into medicine, to neurosurgery as quick as possible.
Okay, very good. Any comments or questions from the panelists?
Yes, John. Eric Sidney here. Yeah, my question is about those who speak multiple languages. What are their tracts like, and the question to Mike, have you had this kind of patients? What's different with this kind of patients?
I can't say with regards to tracts, and part because when you map people with multiple languages in wake surgery, the language sites are right next to each other usually. They're distinct usually. They don't overlap most of the time, and they're very close to each other. In fact, when I was at UCSF, Eddie Chang did a sign language mapping, and the language systems were very similar, except for the language areas were closer to the hand motor cortex than the face motor cortex. That was the only difference. So the interesting thing that's come out of the literature on it is actually some of the fMRI literature, and it's actually about Chinese-speaking patients. And what they found is that compared to people who speak an Indo-European language or other languages, the Chinese brain has more right-sided language activity. And the hypothesis on it is that the right side of the brain is part of prosody, which is the tone of speech, which is critical to Chinese speaking. So their brains are organized a little differently. Now, whether that goes into the the known difficulty of English speaking people speaking Chinese and vice versa is an interesting question. But for the most part, I've met people in Hindi, Sinhala, Chinese, Mandarin Chinese, Cantonese, Vietnamese, Spanish, of course, and German. And Catalan. And I found that convincingly that most of them, their language, they have unique sites that are right next to each other and generally don't overlap. They're usually about this big.
Thanks. Second question. You spoke about machine learning. Have you had different results from the machine learning of patients from, say, the United States and then from other ethnic groups? Because I would like to know if at the end of the day, we'll be able, for example, in Africa to just get the data from the US, or we have to come up with our own data.
The answer is you can come up with your own data. That's 99% of the brain is going to be very, very similar. The reason we know this, and again, I don't know if there's really been a true continental study, but if you get into the what's called consensus connectomics, at least across European populations, a consensus connectome is that, let's say I take 100 people and I look at the connections, the main connections of their brain, and I rate what percentage of the population has that connection. The motor cortex and the motor planning systems are the same in everybody, right? They're very, very minimal differences. The further you go towards the frontal pole, the more it becomes unique to the individual. So what ends up happening is by the time you get to the frontal pole, they're like a fingerprint. You can tell people apart. And that's where most of the difference is. But the vast majority of the brain is fairly fixed. And it's basically based on Euclidean distance from the basal ganglia. So the further you're away from the basal ganglia, the more that becomes, you can do whatever you want. So even in the most unique scenario, but if you take normal Africans, they're going to have most likely are going to have a lot of the same connections. I don't even know if it's been studied. It wouldn't surprise me if it had. It's an interesting question. But for the most part, the vast majority of the data is going to cross over. It's crossed over in every other population people have studied.
Then maybe a last question about neurosurgical practice in the future. From what you said, neurosurgical practice will have to be more and more minimally invasive. Do you think that the future neurosurgery will almost be non-operative in the sense that you have to avoid most of these lesions to these connections?
The answer to it is that would be the dream world, of course. But let me just talk about the disease I know best, which is glioblastoma. If you take the average glioblastoma, we know from genomic profiling that it has somewhere between 30 to 100 different genetically distinct clones. So while it'd be great to have a drug that wipes that out, let's be realistic here. I don't know if cytoreduction is going away in my lifetime. I think my job's pretty safe on that. Of course, the best thing possible is you go take some pill and it disappears, right? It'd be great, but you get down to it, people are still going to get clots. They're still going to have subdurals. They're still going to have trauma, so at the very least, think about all the patients that have trauma that we don't do anything for. Well, the question is, should we be reorganizing these people or doing something, right? They sit there, they don't do anything. There's so many questions that you can ask about this. But the answer is, the dream would be, if you really get down to the best possible scenario, is if we can't eliminate surgery altogether, that you just have a robot do it and you just kind of look over your shoulder and make sure the robot's doing its job correctly, isn't on fire or something. That would be the best scenario, because there's no way you can be more precise than a robot. The problem is that the robot can't make all the decisions that we're talking about. AI is just not that sophisticated now. So what you have to do is we have to be able to tell the robot what it should be doing. We've got to work through the algorithms to make it to the level where it can be superior to us. And what's a really unique time to be alive in this situation is that robot computers and machine learning have reached the point where that kind of stuff is totally possible. This is not science fiction. This is, if you look at the machine learning, especially deep learning and some of the AI algorithms that are out there, they really have the power to do some good. One of the challenges is what people have used them for is to sell ads on Facebook and stuff like that, or spy on people, or, who knows. But the answer is they should be here to save humanity. And when I became familiar with coding and computers, I just became shocked at what was there and what we weren't using, or we weren't even aware existed. And it's really amazing. So we're working very hard to try to turn that loose on the brain.
Okay, thank you very much.
Yeah.
Yeah, I'd like to comment on that, Mike. That's one of the values, I think, of this interface. It'll allow neurosurgery to interface with the robotics community, especially in places like China, where you know it's strong. And I'd like to welcome Iype. Hello, Iype. You want to comment with Mike, for Mike, what Mike has talked about, the connectomes? I know you met Mike before. Let me unmute you there, Mike. Iype, go ahead.
So, John, I'm going to hear out Mike again. And since I'm in the process of designing a robot, maybe I'll get back to him but it's not a robot which is going to operate independently. It's going to help the surgeon. But right now, I'm going to talk about a small talk about a white-necked A-comm aneurysm that we did maybe a couple of days back.
Okay, let's wrap up the questions before we move on to your presentation. Any other comments or questions from the panelists on Mike's talk? I have one, if no one has one.
Hold on. Hold on. Someone's asking a question, but he's muted.
Okay. Yeah. Again, I'm missing things there, Mike. I gotta bone up.
Yeah. He's Mr. 614.
Okay. Okay. Can you see his question?
No, I can't. I can't see.
Okay. Well, I have a quick one, Mike. Can you talk about your studies in China?
What we're working on, we have software that we've created, and connectomic software that can basically it's in the cloud that can be plugged onto almost anyone's scanner. Where basically you can just order a scan with our machine learning models, connectomics, graphs, all sorts of stuff plugged on the back end of it. They push it into the cloud. What comes back is the data. Pretty much the goal is to get this to almost anyone in the world, as long as they have a scanner of reasonable quality. We're implementing in China first for various reasons, but we're eventually planning on taking it worldwide.
Okay. Well, it sounds pretty exciting.
Yeah. So, we have different groups in Singapore, India, Malaysia, the United States, Canada that are all interested in it. We're in the process of building that out and troubleshooting it. But pretty much, probably 6 months. It'll be ready 6 months worldwide. But in China, we're going to be pioneering it and beta testing in 3 months.
Okay. Yeah, a lot of research is being done in neurosurgery in China, right? Besides connectomes and.
Oh, they're doing everything there.
Yeah, we'd like to really plug into the research community. And Mike is probably going to come to Beijing in September. So there's going to be a lot of neurosurgical people there. You'll be talking to people about connectomes there, neurosurgeons, correct, Mike?
No, they've been inviting me, but I'll be there.
Oh, okay. So, well, you're welcome to come to our booth. Iype, we're going to have the ACNS neurosurgeons, and hopefully the Africans will be with us there, the African young neurosurgeons. You're going to be there, right, Ulrich?
In Beijing?
Yeah. At Beijing, yeah. Yeah, Beijing, yeah.
Oh, well, yeah. You have a question?
In September.
Yeah, I'm going to be there. Yes, I'm going to be there in Beijing.
Iype, you're going to be the center of things here.
Can I make a comment?
Yes, please.
Yeah, Mike, it's a very fascinating talk. It's indeed very, very interesting. And in India, we have people with multiple languages in each area. When they have some brain surgery or trauma, the mother tongue recovers first, and then the remaining languages takes very long time. Do you have any reason for this and any studies in this area?
I don't have it from the connectome side, but there's actually a very interesting explanation from the neuropsychology side. So for example, if you look in the study of aphasia, which they've been doing for decades, it's a well-known phenomenon, not just the mother tongue, but also just in general. So, for example, when you have an injury to the left temporal lobe in your left temporal lobe dominant, assuming that, you don't basically, it's not random, the type of deficits you have. What they call it is the narrowing of the neighborhood. So, for example, if you were to ask, what are these? The first thing you would lose is the word glasses. You would call it, you may not be able to come up with more than one word for it. You may only have glasses. Then you would call it, jewelry. Then you would call it that thing. Right? So you become more broad. It's because probably the language system is organized in a hierarchical fashion. And certain words that are more commonly used that are higher in the hierarchy are more overrepresented. So the reason the mother tongue is probably more preserved is that it's represented in more places.
Okay.
Because if you think about it, it just makes sense because you've dedicated a bigger portion of the cortex. It's going to sit on top of the hierarchy, and probably the second languages are packed in terms of the mother tongue. Like for example, I speak Spanish, but I don't think in Spanish, right?
There's a couple of people you haven't met. Mogi, can you hear me okay? Mogi's from Sudan, and the connections aren't great now on the internet. I really appreciate him coming. Can you hear me, Mogi?
Hello, John. I am hearing you.
Hello from Sudan.
I'm fine.
Yeah, that's important to know right now from Sudan because it's been a hectic time there.
Yeah, thanks for coming, Mogi. And we'll be sending you the recording of this presentation. Any other questions or comments before we move on to Iype?
John, I have a question from Michael. We were talking about the implication trauma surgery, okay? But one question I have is, one, what kind of facilities do I need to do this kind of procedures? And two, how long it takes me to have the results? Because if I have a trauma patient that is really, really in bad shape, the idea is to get it into the OR as soon as possible. So how long will it take me to do this?
I don't think that connectomics is going to have a lot to offer in the acute trauma period, because I think that number one, the injury's been done, so you can't pick a good injury point. And B, you don't have the time for it. Where it has a role in trauma is after the fact. Okay, so the ICP's monitors out. The patient's still not waking up. Can we do something else to get them to wake up or be more alert or make their activity better? First, you got to save their life. So pretty much almost anything you do in there at 2 o'clock in the morning when the brain's bleeding is do what you got to do. And you just don't have time for that. You don't have time to go do DTI processing. What we're more interested in is, okay, now that the injury's done and the patient is not getting better or they haven't got better enough, is there something you can do to make life better? And that is a huge question, right, for that area. And the fact that there's a safe, non-invasive, almost no risk treatment that takes 8 minutes, you can do it in a week. And we've seen some people substantially improve. I had a patient who came in with a radiation-induced injury to the dominant hemisphere from long-lasting glioma, who came in wheelchair-bound, who's walking down the hall after a week of treatment. Now, that doesn't mean everyone gets better like that or that every deficit, but we should be looking, we should be trying, right? And because what else are we doing for these people? Nothing. We send them off to, we have had people we've been able to get to consciousness again. And it's the DMN that's the problem. Now, if you have a brainstem stroke, I mean, that's probably not going to be reality, right? Not all these patients can be salvaged like that. But the fact that if there's an idea that there's any of them that you can just turn on a magnet and they're going to be a reasonably okay person in the future, it's worthwhile. So the question is, where do you target? Who do you target? What does it look like? We don't know. No one's ever studied this. There's no data. No data in comatose patients with fMRIs. But now that it's become so easy that we're going to be collecting it worldwide. Probably by the middle of next year, we'll be everywhere anybody wants to be.
Well, sounds exciting. Okay, any more closing comments or questions before we move on to Iype's presentation? Okay, very good. Thank you very much, Michael. We look forward to hopefully more webcasts on Connectomes and its development. Okay.
All right, thanks.
Very good. I just want to give a talk. You can stay, Mike. Whatever you want to do. And thank you very much. Okay. Before you, go ahead, Mike. I'm sorry, I cut you off. Go ahead.
Oh no, it's almost midnight. I'm just gonna probably head to bed.
Okay. Okay. Very good. Okay, Iype, welcome. And before you start your presentation, it looks like you're ramping up to do another smartphone presentation, which is great. Let's meet the panelists. Can you please introduce yourself, Sughrue? I think you know Iype. Go ahead.
Yeah, my name is Sughrue.
Of course you know
I'm from Peru. I'm really glad to be here and see you again, sir.
That's great. You were just in Nepal, right, Sughrue?
Yeah, it was like 2 weeks ago. I'm here now in my hometown, Peru. So I'm still used to do the one that is here Sunday, that is the holiday, and it's like 6 a.m. So it's worth the effort. So.
Well, Iype's network of neurosurgeon fellows is starting. Okay, the next person, I don't know your name. I just have a phone number here. Go ahead if you want to.
I'm Dr. Venkatramana from Bangalore, India. Iype, is nice to be here with all of you. John, great meeting you again.
Very good. Welcome. Mogi, can you hear me okay?
Yeah, hello.
Yeah, you know Iype, Mogi, I think.
Yeah, I know him.
Yeah, you've known him for a while.
Yeah. I'm Muji Imam from Sudan. I'm a neurosurgical resident in my 4th years.
Very good. Welcome, Mogi. And Ulrich, could you please introduce yourself? Can you hear me, Ulrich? He may have stepped away.
No.
Go ahead.
Yeah,
go ahead.
I'm Ulrich Sidney, a medical student from Cameroon and a future research associate at Harvard.
Very good. Welcome. Natalie, can you hear me? I guess not. She may have stepped away. Let's see. Who did I miss?
Hello.
Oh, go ahead, Natalie. You talking?
I'm Natalie Christel. I'm a medical doctor in Cameroon and aspiring neurosurgeon.
Welcome. Sorry about the feedback there. Okay, Iype, welcome, and it's all yours.
Okay, guys. So here we are again. I'm going to be talking to you about white-necked aneurysm that we clipped maybe a few days ago. So let's get straight into my my sharing the screen. Let's do this now. Okay.
You're doing this from a smartphone, right, Iype?
Yeah.
It's incredible.
Okay. So can you see this?
Yes. It's not big screen yet. There it is. Okay.
Right. So we're starting.
Yes.
So this was a white-necked aneurysm. As you can see, can you see the white neck?
Yes.
Everybody? Sorry.
Yes, Iype.
Yeah, right. So we are exposing right now. That's the optic nerve, and that's a carotid. So I'm going to do some proximal sylvian dissection there. I'm using a diamond knife. So we've not done a real skull base craniotomy or anything. We've just done a usual pterional craniotomy. And now I'm opening in between the optic nerve. So that is the optic nerve. I'm going medial to that, and I'm opening. That's where the aneurysm is. So you can see the bleeding already there. So I'm going to open there. So in this kind of cases, you must be careful because sometimes during this maneuver, the aneurysm can bleed. Without a proximal control, this would be dangerous. It has happened. I mean, there is another video of mine in the YouTube where it's happened when we haven't really isolated the A-comm. We haven't really isolated the A1. We had a bleed like that. And there is another video on YouTube. And you can see the A1 getting clearer now. Can you see, guys? A1? That's the A1.
Yes,
Okay.
Right, that's the A1. And so I'm slowly dissecting the A1. That's the optic nerve. And slowly going on dissecting the A1 so that I have proximal control. It's a big A1. So I'm keeping on going on dissecting the A1. Now you have the aneurysm. We have gone far. So you see, this is A1 on one side. Okay. This is the A2 turn. This is the A-comm side and the A2 on the other side. The A2 on the other side is that. And this is the aneurysm. Clear? Is it very clear? Everybody?
Clear. Yes.
Yes.
So this is a very wide-necked aneurysm, but fortunately it's projecting anteriorly. If it was projecting in between the two A2s, it would have been a bit difficult. I would have to use fenestrated clips. But now I'm putting in a A1 clip so that the aneurysm softens and doesn't break when I put the clip in. So I'm going to put the clip in right now. So that is one A2. That's the plane of the other A2. You can see the other A2 there. So I'm going to put the clip in between these A2s. That's a clip, and you can see the A2 there. You can see my suction is on the A2. That is the ICG. My suction is on the A2. And that's the aneurysm which is clipped. And well, that's it. Thank you very much.
Okay, very good. That's a quick presentation. Okay. Any comments or questions from the panelists? Sughrue, you have any? Are you there, Sughrue?
Yes, John. Here.
Oh, okay.
It was really a fast presentation. So, sir, you only get control in the proximal, in the A1 ipsilateral. I mean, just one of them.
Yeah. There is no need for everything because this is a dominant and A1, and the other A1 is very, very small. So I generally, if there is an aneurysm projecting from one side, I don't go dissect everything. And when you are dissecting the other A1, you're going posterior to the A-comm. There's no need for that. Actually, you can just put a clip on one A1, and then if it ruptures, if this aneurysm ruptures, you with one proximal control, you'll be able to deal with it if you have dissected the aneurysm properly. Well, if you have not dissected the aneurysm properly, even if you put a clip on all the vessels that you know about, you're not going to be able to clip it properly. So the whole secret of this thing is to, dissect the aneurysm properly. So as much as you can, you put your effort on dissection and not on proximal control. I always tell this to my boys, and when you are walking on a tightrope, don't look at where you can fall. Always look at where is your next step. So it's very important in aneurysm surgery also. Don't look at how many controls you have. I mean, some people are they are so obsessive that they dissect out A1, both A1s, both A2s, and probably they'll dissect out the pica also before clipping the A-comm aneurysm. There's no need for that. There's you just get your dominant A1, and then you're not expecting, you're prepared for a rupture, but you're not expecting a rupture. You're expecting to clip the aneurysm without any problem.
Second question, doctor, what was the condition of the patient and how it's doing now?
Well, The patient came to us with a WFNS 4 grade. He had an acute kidney injury, so he is, he is still on a ventilator, on a tracheostomy, and his renal status is being taken care of. I hope he does it. CT-wise, he looks good. There's no more problems on the CT, so he's looking good right now. But once his kidney problem is sorted out, then I hope we will have him without any problem.
Do you use an endoscope to check the complete occlusion of the neck, or only rely on ICZ?
No, I don't use an endoscope. I mean, when I was in Fujita, I have seen this technique, and when Professor Sano used to use it, and Dr. Kato also used to use it, but I don't use it. I mean, yes, of course. I mean, you can say that, yeah, I mean, there may be the A-comm, the neck may not be fully occluded, but I see both the tips of my clip going across that, and in my mind, I know how's the aneurysm shaped. Like, this is what I depend on. If you need to use an endoscope, this is a space which is 5 millimeter in size. If you have to use, I mean, I was last Sunday, actually, I was presenting a case where, or maybe before that, I was presenting a case where I was using an endoscope for visualization of third ventricular tumor, where we did a supracerebellar infratentorial approach, and we wanted to see how how it could be done with the endoscope as well as the microscope. Yeah. So, but in this case, and we have the Mitaka arm as well for fixing the endoscope, but I don't use the endoscopes in aneurysms unless maybe in exceptional scenarios.
Thank you. Very nice, Ajay.
Thank you very much.
Any comments or questions from the panelists? Don't be afraid. Okay.
Any other questions?
So you said he was a acute kidney patient, right? So there is a chance of recurrence, of aneurysm in it.
Yes. Yeah, you mean he has CKD, not acute. He has CKD.
Okay, CKD, right. So
yeah, he has CKD, and we don't know what is the cause. Our critical care team is still working on it. But right now he has an acute kidney injuries. I mean, in fact, his urine output in the morning was very low. So his BP is keeping stable, but his urine output was low. His on echo, he had some left ventricular motion problem and all that. So, but other than that, we are hoping that he makes it. Yes, but as you said, there is a chance that in CKD patients, that this aneurysm, that vessel wall thickness, vessel wall problems can occur, and there can be aneurysms.
Okay, thank you, sir.
Yeah, very good. There are a couple of panelists we haven't met yet. I think I'd like them to meet Iype. Inayat, okay, Inayat, I believe there's a couple more. Nathalie, I believe. Let's see. S, have you met formally? Have we met you? S, I just have S here on your screen.
Yeah. Hi, I'm Sampada. I'm from India, Mumbai. Actually, I finished my undergraduate MBBS from KM Hospital. And now I got into MS surgery, and I'll be starting with my residency from 2nd May. So, and I am interested in neurosurgery, so I follow this channel.
Very good. Welcome. Welcome. Could you take a second, Iype, to show the panelists how to present on a smartphone? Because there's a couple of them accessing this conference, and the resolution of your illustrations are excellent from a smartphone. It's incredible. Could you quickly show Iype, a couple of the panelists, how to do that smartphone presentation?
Hey, John?
Yes. Yeah,
John?
Yeah. I can hear you.
Hello?
Yes, I can hear you. I guess maybe your audio is off. You can hear me, right? Yeah, I think
Hello.
you lost your audio there, right? You may have pushed the audio button. But if you can see,
John?
yeah, I can hear you. I can hear you. Okay, maybe you're muted. Okay, well hold on.
Hello?
Yeah. Okay.
Hello?
Well, anyways, I'll take it up here. I was on a phone call.
Hello?
What we do is you go to the bottom of your screen. You go to the bottom of your screen, and on the smartphone, there's a couple of options. One of them is share, and that's where you can start your screen sharing. You see that S at the bottom? You see share. Okay, touch that button on your smartphone and it says share, and it opens up the main screen of your smartphone. Then you can pick what you want to share. And once you try that, give it a shot now. And whoever else, Iype, can you hear me yet?
Yeah, I can hear you.
Okay, can you quickly show how to do that smartphone? Because excellent resolution on those studies.
Well, I'm not the expert, John. I just click on the Zoom link that you gave, and rest everything the phone does.
Okay, it's all right. I'll do it later. Stick around after. I'll show you how to do it. Okay.
John, I'd like to ask a question.
Yeah, go ahead. Good. All right.
Please. It's about the post-operative care of aneurysms. I've seen quite a few cases of aneurysmal clipping over here, but usually the problem is with the post.
Breakup. I don't know if you caught that. Ulrich, could you repeat the question? Ulrich, the last comment.
No, I didn't hear the question. I just.
Do you have any tips to share with us?
Hello, I didn't hear the question.
Yeah, go ahead.
Yeah, the question was, can you please share a few tips about the post-operative care of aneurysmal clipping?
Yeah, we make sure that the BP is okay. Then we make sure the CVP is okay. And we make sure the patient is well hydrated. These are the three things. And, these are the three best things that you can do to avoid vasospasm. We start off with nimodipine. Intraoperatively, if you can give papaverine, this is good. Some people give, if there is vasospasm, some people give intraarterial nimodipine. So, well, this is about it. And rest is general care. Then there's, I wouldn't be the authority to talk about that. Although the authority would be my critical care team, then maybe I can get Sharanya to talk about this. But I guess this is about it.
Okay, thank you very much.
Yeah, sure.
Okay, very good. Any more comments or questions before we close? Okay,
yeah,
very good. Go ahead, Nathalie.
I have a question.
Go ahead.
Yes, I want to ask, please, Dr. Iype, what are the main complications you find when you do a clipping of an aneurysm?
What are the complications that when I deal with an aneurysm?
To encounter the main ones.
So starting with rupture, sometimes when you're clipping an aneurysm, it can rupture intraoperatively, which is a bad thing to have. Then you can have vasospasm. After you clip the aneurysm, everything went well, but then you may have vasospasm of some perforator or maybe even a main vessel. This is bad. Well, other than that, other things like meningitis, other infections, ventilator-associated pneumonias, these are the main things that I encounter.
Okay. Actually, I was asking because, I was in the neurosurgical department of the central hospital, and the main aneurysms who came to the hospital were already ruptured. But I don't know, when an aneurysm is ruptured, is there again a necessity to go and clip? And if there's a necessity to go and clip, what is the best technique to use to these patients? Is it that we should go directly as an emergency, or we should first wait and treat the secondary complications? Then when the patient is stable, we'll go for the surgery.
You don't wait for this, Natalie. You don't wait for aneurysms. You don't manage every complication and then go for the aneurysm, because the aneurysms, there's a 4% chance of rupture every day. You don't want to take that chance. So, of course, if the patient is very unstable, of course, you can stabilize the patient in a day at the max. Your critical care team would be doing that in a day at the most. And then after that, hey, Jamil. So one day you can do that, and after that you go for the aneurysm. You don't wait.
Very good. Okay, any more comments or questions for Iype?
So why not choose coiling over clipping then? If the complications are, or what are the indications of coiling rather to be chosen over clipping?
Yeah, see, the thing is, in the world there are two types of people. One are the coilers, one are the clippers. So I'm a clipper. So I would ask I'd ask you the same question. If anybody asks me, I would tell you that I can clip any aneurysm that a coiler can coil at 1/100th of that price. So,
okay.
So that is my answer. And, we live in Nepal. I'm from India originally. So,
yeah.
I mean, I don't think the third world, the low-income countries are ready for coiling.
Correct.
Most of it is not ready for coiling.
Yeah.
And if you get interested in this fancy thing, then, it's a pretty easy thing to do. It's you're not exposing the aneurysm, you're not doing a craniotomy, your learning curve is much, much better. I see people becoming experts in 2 years, which you can never do with an aneurysm. I mean, if you're doing aneurysm surgery. So, I mean, it's an easy thing to do, but the elegance of aneurysm surgery, I mean, well, I shouldn't be talking about that. But then, at the end of the day, most of my patients cannot afford. I mean, not one of my patients can really afford coiling.
Correct.
So
I agree. I come from this. You must be knowing Dr. Atul Goyal, right? So I have studied my MBBS from the same college, and same situation in India. People cannot afford really costly surgeries. So yes, I agree with you.
In the West, what's happening is all these aneurysms are going for coiling, and those cases which are difficult for coiling, they're asking them to clip. And when these guys are not clipping even 10 aneurysms a year, then it becomes a bit difficult for them to clip a complicated. For example, the white neck aneurysm that I just showed right now.
Yes.
It'll be pretty difficult for coiling also. Well, if they have these new devices, I mean, every time they have these new fancy devices. But I was just talking to Ashish about this. I mean, this is a conversation which is never going to end. But I like the beauty of clipping. I like the elegance of aneurysm surgery. And it's challenging. Of course, it's sometimes very difficult. Sometimes it's really, really difficult. But it's an interesting subject. Maybe when you do your surgery and when you go on to become a neurosurgeon, I advise you to take up vascular surgery. I'm coming for Professor Goyal's meeting, and I've been invited as a faculty. So he's having a meeting next week or something. So in less than 10 days, he's having a meeting. So I'm there on 21st in Mumbai. So I'm delivering a couple of lectures there as well.
We have
I'll try and meet, sir. Thank you.
Okay, we have one more question with a longtime follower and a possible future fellow of Nepal, Rakesh.
Mm-hmm.
Go ahead, Rakesh.
Hello, sir. Dr. John. Hello, Dr. Rakesh from Kolkata.
Hi, Rakesh. I can't see you, Rakesh.
Rakesh, is your camera working?
Hello. Camera
may not be working.
Yeah. I'm from Kolkata, and today we have a 2 days conference. Professor Sano from Japan is here, Fujita, and all the big people are here. Robin Sengupta, and just today I heard clipping versus coiling from Professor Suresh Dugani, who is from my hometown. So apart from these things, I have heard this coiling plus clipping many times in conferences. Today he highlighted about the long-term results of ISAT trial and BRAT, in the sense the follow-up of these patients after 6 years, 9 years, and 15 years. The results are changing.
I know this
the results say that clipping is better than coiling on the long-term follow-up in many things. The death rate is 6 times more in coiling compared to clipping in long-term follow-up. That is 6 years, 9 years, and 15 years. And also the complete obliteration is much more higher in clipping compared to coiling, and the resurgery rates are more in a long-term follow-up in coiling. So
yes, absolutely.
Then some people called Masson et al. have done a long-term follow-up, that is follow-up after 9 years and 15 years. So the results are shifting. And he also mentioned that in US and Germany, the sales of clips have gone up, which itself indicates that clipping is taking over coiling again for these reasons. So I was very happy to hear that. So I just wanted to share this.
Yeah, I mean, see, I don't say, for example, for a basilar aneurysm, if I have a coiler present and if the patient can afford coils, I would ask them to go get coil, because the basilar clipping is not easy. It's not that it's particularly difficult. Well, in fact, we expose the basilar quad every single cystinostomy. Our endpoint is opening the membrane of umbilicus and exposing the basilar quad. So it's not, I mean, we've done over 1,000 cases. It's not very difficult for us. But on the other hand, to put a clip on a ruptured aneurysm is not the same thing. We've done that many times, but I would ask, if there is a choice, maybe I could ask for a coiling. But the rest of the cases, I don't know. I mean, I would rather prefer clipping. And even in a basilar, I would prefer, personally, if you ask me, I would prefer clipping.
Okay, sir. Thank you. Thank you so much.
Yeah.
You know, go ahead, Rakesh.
Over the next 3 days, we have aneurysm surgery live by Professor Sano here in Kolkata, sir. I just wanted to mention.
He is my mentor. I was with Professor Sano in Fujita. Yes, he was my mentor. And Professor Robin Sengupta knows me very well. In fact, he called me a couple of months back. So please convey my regards to Suresh, Sano, and Professor Sano and Professor Robin Sengupta.
Sure, sir. Thank you so much.
Yeah, sure.
Rakesh, you want to go to Nepal, right? To be
I'm coming to Nepal. I'm planning the month. So I'll finish my residency in the next 3 months. I'm planning the month when to go. I'll talk to sir.
You're most welcome. You're most welcome.
Yes, sir. Thank you.
You have 6 fellows there now, right?
Beg your pardon?
You have 6 fellows there now in Nepal at Nobel Medical Center?
Well, right now I have 1 fellow, but we had many fellows from all over the world. Right now I have 1. I will have maybe a couple of more joining soon.
Yeah, it kind of varies the number, right? It'll go up next month. But at one point, I think you had 6 fellows there.
We have the AMSRS. No, we've had much more than 6 over the last 1 year, we've had much more than 6.
Oh, okay.
But right now, the AMSRS ACN has started a fellowship, short fellowship for residents as well as neurosurgeons, junior neurosurgeons. So the number is expected to go up.
Hey, who would you urge to come to Nepal now? Do you want to encourage people to apply?
Yes, yes. I mean, we have a Sughrue. Maybe Sughrue should be telling about his fellowship, and we have Gracian also. Gracian, yeah.
Yeah, why don't you show us around? That's fine. That's the great thing about a smartphone. It's like a portable camera.
Gracian, you can talk about your fellowship, and maybe Sughrue. If Jamil is around.
Yes, I am.
Yeah, that would be great. Yeah, that would be great if we could do that, right?
I'm sure people like to hear that. Yeah, if you guys could tell about your experience, maybe I can go off and you can just hear.
Hey, thank you, Iype. I know you're busy. Thank you very much.
Thank you, sir. Thanks a lot.
Hello, could you please introduce yourself and tell us what you're doing in Nepal?
Okay, I'm Gracian Guenero from Zimbabwe. I came here about a month ago to do my fellowship in skull-based neurovascular and trauma with Professor Iype Cherian. So I was sent here by Professor Kazadi Kalangu. So I completed my neurosurgery training in November last year, November 2018.
Okay, so you're doing a fellowship of a couple of months there in Nepal with Iype?
Yes.
Okay, very good. Very good.
So my experience has been, so far, I've been learning a lot about skull-based aneurysms. Okay. So I've seen a couple of approaches, and it's very good. My understanding has become a lot better. It's like, before you see this and you are trying to study it, looking in the neurosurgery atlas, it's difficult. But after this, things became totally different. Now, when you look at the atlas, you can just tell. You don't have to read the...
Yeah. It means more, huh, the atlas?
Yes. And when you see things being done and the experience makes you more confident. It gives you the faith that you can do more. You can also do it. Yeah.
Okay. Have you met Ulrich yet? Are you friends, Ulrich, with
No. I know Dr. Gracian was already here last week. He was 2 weeks ago. 2 weeks ago, with when I was giving a presentation, he was at the back already. And
Where was that?
He was on Neurosurgical TV. I think 2 or 3 Sundays ago.
Oh, great!
Yeah,
excellent.
He was already presented. So.
Well, look at the way we're including Sughrue in Peru. He just got back from Nepal, and now he's keeping in touch with what you guys are doing there in Nepal.
Yeah, I mean, it's always good to try to keep in touch with the people that you are, especially with Dr. Iype. I'm trying to be here all the Sundays, even that it's a holiday for me. But
well, podemos hacer en español también, domingo.
Podemos, but I think a lot of people it's not gonna understand what we are saying, so it's more polite to speak in English, I think.
Yeah, well, yeah, we could do them. We do them in Spanish now, and of course, you're welcome to be part of that community.
Yeah, I mean, the idea will be to find more people that. And our idea with Professor Iype was to try to improve the knowledge also in Spanish, because there's a lot of people that doesn't speak English, so doesn't understand that. And like Gretchen says, once you understand all this concept, once you have been there in Nepal, and you try every day to understand a little bit more. And Professor Iype is really exquisite about explaining things and make you understand why he does one or other thing. And also, he's really good about explaining you the anatomy. So once you understand that, as Gracian says, it's a completely different mindset. I mean, you see things different. And besides, for all the facilities that they have there, you also open up a little bit more to what you can achieve especially if you are a young neurosurgeon. I mean, you start to develop this kind of sense of you want more. You want more for yourself. You want more for your people. You want more for the patient to be that you are taking care of.
Very good. Let me just quickly show you. I don't know if you've seen it, but we have a community of Neurosurgery TV. We've done a fair amount of conferences online, and of course we'd like to continue that with you. So, any more comments or questions? Rakesh? No, Rakesh is an Indian neurosurgeon. I believe he's training near New Delhi. He is coming to Nepal, right, Rakesh? Are you still there, Rakesh? Yeah, he'll be coming there shortly. Let me try to get him. Rakesh, are you there? He may have stepped away. Anyways, there'll be more fellows coming to Nepal.
Mm-hmm.
I guess it's variable, right? It can be 1, 2, or 3 months, or does it have to be 1 month, or what's the deal on that?
I think it's 3 months.
3 months is okay. Okay.
Yeah. 3 months plus.
Okay, very good. You plan to be there 3 months or longer?
3 months. A little over.
How do you like them? Have you tried the momo yet? Those dumplings called momos? I know Sughrue has.
I did. I have.
I lived on Momo there on the 5th floor cafeteria in the Nobel Medical Center. Do you guys go to that cafeteria?
Yes, I do. I get some coffee there.
I always used to bring my computer and go to the cafeteria and drink coffee up there.
Oh yeah.
The Wi-Fi signal is pretty good up there.
It is. Well, now throughout it's good. So yeah, even in theater it's very good.
Very good. I'm sure people don't want to hear this kind of conversation. Anyways, thank you all for coming. I'm going to stay here. I'm just going to stop the recording, but you can stay here as long as you want. So thanks everybody for coming.
Thank you, sir.
Okay, yeah, we're still broadcasting. We're still on Facebook. I had trouble with Facebook today. We're not recording it, however, we're still live on Facebook. Because we're on YouTube. I had to kind of manipulate it because Facebook wasn't working, so I put it on YouTube. So anyways, yeah, that's great. We're having a really strong showing from Africa. Wow, that's great. That's really great. And the Connectomes, I wasn't listening, you guys. Had you guys heard of Connectomes before? Have you studied them at all? I'd never heard of them.
Never.
Have you heard of them, Natalie?
Never.
No, I've never heard of that. Has anybody ever heard of Connectomes before? Sugar? No, I've never heard of them. That's what Mike talked about. And Mike he's a big neurosurgeon in Oklahoma and in the United States because of what he said. Minimally invasive and keyhole. I believe keyhole. Do you guys know about that? Keyhole type of excision of glioblastoma.
I think keyhole we all have heard, but I actually have a more. I was intrigued about this treatment that he is trying to put on the patient. I mean, to recover and everything. Maybe it will be great if you can ask them. Maybe he can talk about it, not just like another lecture about this treatment and the implications in recovery of the patient, because it was really, really interesting.
Yeah. Well, Sugar, he's a good contact for our community because he does a lot in China, and we certainly want to develop a strong Chinese neurosurgical channel, and he goes there a lot. In September, there's a big conference in Beijing. Neurosurgical TV is going to go there. We're going to have like a booth. Iype's going to be there. I don't know if you can make it from Peru.
I will definitely be there. I'm really, really keen to that.
Well, we'll put you to work at the booth.
Of course.
And you'll be on the computer televising to Latin America.
Nice. It will be really, really nice to do that.
Yeah, no, we can do it. We're going to have, okay, hopefully, ideally, this is ideally, is we'll have like 10 computers and we'll have 10 different neurosurgeons communicating with their part of the world live. Hopefully we'll have at least a couple of live, besides, of course, we'll have the conference, which, you know, being in a booth, I really can't go that much, but we'll be talking to neurosurgeons as they stroll through, because as you know, in a conference, sometimes you stay, sometimes you go, wander around. Hopefully we'll have a centrally located booth where you can hang out. You go ahead, Ulrich. Hey,
John, I'm leaving, John.
Okay, thanks. Hey, that smartphone is working out great, huh?
Yeah, it is.
Well, you're showing people that they can easily give a presentation, quality presentation from a smartphone.
Yeah, provided that you have your presentation on YouTube and your internet is good.
Yeah, the internet is good. Yeah, it's got to be definitely good. But we had a good Africa showing here, right?
Yeah.
And Peru, India. This fantastic. I guess one of Dr. Kazadi's associates there now, correct?
Yeah.
You got him from Dr. Kazadi? You've heard? Okay, very good. Okay.
See you then, John.
Okay, I'm going to stay here. Thank you for coming. Sugar, I want to talk to you in just a second, okay? Okay, thanks, Let me show you around, Sugar. I want to show you the website of Neurosurgical TV. We've done a lot, actually. Are you there, Sugar?
Here, John.
Okay, let me take you on a little tour, okay? Let me share the screen. We've had some, okay, oh, this is great. We're televising a conference next month from San Jose, Sugar. Okay, let me see if I can get the conferences. Oh, I gotta log in here. Hold on a second. Let me get the password. You know how that is.
Hey, John, and what days you are broadcasting in Neurosurgical TV in Spanish? I mean, what?
Well, we can restart. I haven't been paying too much attention to the Spanish community, but I'm going to start doing more conferences. We used to do them on Sunday afternoon. We certainly can restart that if you want to do a presentation next Sunday in Spanish. You're welcome to. I'll be glad to arrange it. We could do it in the morning at whenever we can do it.
Yeah, right now for me, I'm trying to push this thing about hysterostomy. I would like to start here in Latin America because here they're not doing it. Okay?
Well, that would be excellent.
I think that will be a good point of start to make maybe a conference and try to pull more people through this community, because actually it's really, really good, you know, because the presence and also the education of young neurosurgeons, the residents, sometimes is really, really difficult, especially when you don't have mentors like Dr. Cherian. So the facility that we have through this complete set that you are and other people that have arm of Neurosurgical TV, I mean, it's really, really good. It's really good.
Well, we want you to help us develop it. I mean, we potentially, I think the Spanish neurosurgical community is the most hungry of all neurosurgery communities that I've seen. They really like this technology, and I think we're going to continue to do it. And I'd like to restart it. I think an excellent idea. Are you available next Sunday?
Yeah, John, but I don't know if Sunday is going to be the best.
Okay, what day is good for you?
No, I mean, not for me. I mean, you have to see, for example, for me to do the support Sundays here, it's really, really difficult. Not difficult, but it's kind of more challenging because it's a Sunday, which is a holiday, okay?
Yeah.
And 5 p.m. time to Nepal here is like 6 a.m. So a lot of people that work, for example, takes this day as a day off. So it's really, really hard to be here. For the Spanish community, maybe it'd be a Friday afternoon kind of night, or maybe...
Okay, that would be good. That would be good.
That's things that we have to figure out. Now, there is this guy from Colombia, Dr. Rubiano. I don't know if you know.
No, I don't know. I haven't heard him, but I'm not a neurosurgeon. I spend a lot of time on the internet, but not.
Yeah, it's really, really great guy. I mean, I met him in Colombia. I met him also in Italy. He's always kind of giving lectures. He's really, really keen in the learning process. And
could you please screen share him, please? Find his profile and screen share him. Show me.
I will tell you.
You know how to do it, right? You know how to screen share? I can show you right now if you want.
Yeah, but I know how to screen share, but I don't have it right now. I will send it you by email.
Yeah, please send it, because I'd like to Okay, why don't we do this next Friday? What time is good for you?
No, John. Right now, I mean, I have taken 3 months to be in Nepal, so this month I'm taking for myself because my wife is
no problem.
So besides, I would like to do is maybe I will try to find more people here in Lima.
Okay.
I'm gonna try to speak with some of my resident friends, so maybe we can do something like you are doing in Zimbabwe, I think.
So we do it all over the world.
Yeah, I mean, the lectures of anatomy that you are providing.
Okay. They're Cameroon. Most of the students are from Cameroon. Yeah. But we do them in Spanish too, neuroanatomy, with Victor Hugo Perez. He's going to start a series.
But I mean, maybe we can arrange something like that. I'm going to speak with some friends here, and I'm going to try to see if there is a possibility to do a presentation every week, at least for a couple.
Have different people do it, because sometimes people are on call. So every week have someone different.
Yeah. I'm gonna try to find this kind of people that is available to do this kind of stuff, because it's really important. And as I said before, at least for Latin America, I think it's a really, really good way to improve and interconnect between cities, because we are near, but at the same time we are so far that sometimes we don't talk to each other, we don't know each other. So it will be a really, really nice way to start improving the Latin America community.
Well, certainly I'm very eager to do more in Spanish, en español. Cuando yo empecé, Sughrue, hay mucha duda, Dr. Bennett, porque está empezando en español. Pero yo pienso que, vamos a probarlo para ver cómo va. Y va muy bien. Mucho interés en la comunidad española de neurosurgería.
John, ahorita el problema...
Yo fui a México una vez para un congreso. Yo estoy televisando un congreso en mayo de Costa Rica en español con los neurocirujanos de neurosurgería pediátrica. Y está vivo en Neurosurgery TV 3 días en español.
Sí, mira, John, es que en este momento, por ejemplo, yo hoy les tengo que ver lo de recibirme como neurocirujano, y eso es importante. Entonces, a partir de julio, de repente, podemos trabajar así semanalmente en hacer una presentación.
Okay.
Y tratar de ver mira, por ejemplo, para mí una de las grandes ventajas que tiene ahorita Neurosurgical TV es el apoyo que recibe el doctor Cherian. Porque él cada semana da una presentación, lo cual no es fácil muchas veces tomar un poquito de tiempo para darlo. Entonces, lo que necesitamos es también encontrar gente que quiera hacerlo para que, si iniciamos esto de Neurosurgical TV en español, sea una cuestión permanente. O sea, no sea una semana y la otra semana no, sino sea una cuestión de que vaya cada semana por al menos un año para atraer más gente. Y lo genial es de que, como es gratis, a los latinos nos encantan las cosas gratis. Entonces yo sé que mucha gente se va a pegar a este canal. El único problema que yo veo en este momento es el lenguaje. Uno, el lenguaje, que ahorita estamos en inglés, Y mucha gente, lamentablemente, acá en la comunidad latina de médicos, hablo por Perú, no habla de repente de manera tan fluida el lenguaje. Entonces, en inglés es un poco difícil. Y dos, bueno, para toda la comunidad latina también hablo que con la versión ahorita en inglés que estamos haciendo, el problema es el horario, porque es domingo y 6 de la mañana, entonces el único día libre que tienen, usualmente el domingo te duermes hasta las 10, 11, ¿no? Y ahorita, por ejemplo, no he tomado desayuno, tengo acá a mi gato que está al costado, entonces...
Mira, Sughrue, yo sé que toda la gente no va a satisfacer, no puede, todo, no puedo. Yo sé, no puedo. Por ejemplo, esta transmisión en California es 3, 4 de la mañana. Entonces, yo sé que los neurosurgeons de esta parte del mundo no es posible. Pero podemos hacer más tiempos diferentes, cualquier tiempo. Experimentar. Y yo creo que la cosa grande es para empezar. Hágalo. Sencillo, una persona y cada semana así.
Sí, yo creo que, como te digo, voy a conversar con mis compañeros acá, con algunos amigos que tengo de...
Sí, empieza lento, uno por uno. Muy lento. No hace gran proyecto porque va mucho planeando, mucha gente. No. Una persona, una presentación. ¡Bum!
Y lo vamos coordinando. Yo creo que lo vamos coordinando.
Sí, no hay prisa cuando tienen tiempo. No hay prisa. Estamos aquí. Estoy encontrando una persona para
¿Tienes mi número telefónico, ¿no es cierto?
¿Qué?
Mi número telefónico, my cell phone number, so you can reach me through...
Okay. Sí.
Do you have it?
Facebook, no sé. No creo que no. Mándalo, por favor.
Okay, I will send it you right now.
No, mira, estoy hablando con una persona de inversión hoy.
Okay.
Queremos hacer lo mismo calidad de producción en Neurosurgical TV como televisión. ¿Entiendes? Producción, promoción y calidad. Por ejemplo, calidad de transmisión, la calidad de promoción a todos los lugares. Yo estoy haciendo solo, entonces necesito ayuda. No de neurocirujanos, no. Tú tienes empleo, tú estás muy ocupado, pero necesito ocho personas para ayudarme promoviendo en Facebook, estudiantes.
Sí, te entiendo. Mira, yo te he visto, por ejemplo, muchas transmisiones 3, 4 de la mañana, o sea, es demandante. Ahora, como te digo, la idea sí, sería también de que los estudiantes nos puedan ayudar. Para mí la idea, por ejemplo, de iniciar esto acá en Perú es encontrar a alguien también que tenga peso, o sea, que sea renombrado. Porque, por ejemplo, el profesor Cherian, o sea, en Asia es una persona que es muy respetada, entonces, por ende, tiene bastante peso.
Él conoce, Sughrue, él conoce todo el mundo. Sí. Mira, yo he tenido un amigo que tiene un disco en su cuero, algo muy serio, obviamente, y él quiere un neurocirujano bueno en los Estados Unidos, porque está de Miami. Yo pienso que no conoce a nadie en los Estados Unidos, Asia sí, pero él dice que, yo voy a llamar Dr. Benzel, y yo dice que, ¿quién es Benzel? Es el jefe de Cleveland Clinic. ¡Wow! Cleveland Clinic es uno de los mejores en el país. Y él conoce el jefe de Cleveland Clinic. Él está en el rancho de Iype una semana.
Mira, porque el doctor Benzel es el que ha escrito uno de los libros más importantes ahorita en la literatura actual de columna. Es una muy buena referencia. Sí, definitivamente el doctor Cherian tiene muy buenas conexiones, por eso te digo, para mí también es importante el hecho de poder conseguir de repente alguien un poco mayor que yo, que nos pueda también apoyar en esto para que por lo menos tenga un poco más de presencia.
Sí.
Entonces voy a tratar, tengo un amigo que hace lo que es cirugía oncológica todo lo que es tumores del cerebro, y trabaja en el instituto acá. Es muy bueno como cirujano, es muy bueno como persona. Lo voy a tratar de coordinar con él, para que de repente los viernes en las noches, tipo
cualquier tiempo es conveniente para ellos. Si ellos
claro,
quieren otro tiempo.
Por eso te digo, es que para nosotros, por ejemplo, aquí en Perú, o sea, el viernes es un día un poco más relajado.
Ok, bien, perfecto,
vamos. Sábado en la tarde con él también viendo su tiempo, para que sea, o sea, a mí me gustaría muchísimo que sea una cuestión constante. O sea, que lo lancemos por un año, nos comprometamos por un año a hacerlo todas las semanas, una presentación por semana, y perfecto. Y como tú dices, la versatilidad que se tiene con la computadora, incluso con el smartphone, para poder realizarlo, o sea, es genial, es realmente genial. Déjame conversarlo esta semana, John, con mi amigo, y el próximo domingo que estemos acá, nos quedamos un rato y te comento qué fue de la reunión esto. Me has dado una muy buena idea, sería genial hacerlo, y créeme que yo tengo muchísimas ganas de poder llevar esto adelante.
Hey, o cualquier neurocirujano que tú conoces, si él quiere presentar cualquier cosa de neurocirugía para educar, llámame, mándame un email. Cualquier tiempo que ellos quieran, aparte de su presentación regular.
Voy a tratar de coordinarlo yo, uno con el hospital con mi amigo de oncología, y luego con el Instituto del Niño, que hay neurocirugía pediátrica.
Ah, sí, perfecto.
Son bastantes, entonces yo creo, y son muy amigos míos, entonces yo creo que ellos sí nos pueden dar una ayuda en cuanto a esto.
Sí, póngame en contacto con ellos. Yo puedo hablar con ellos informalmente para mostrar, ¿okay? Para mostrar el poder de Facebook, para mandar a Latinoamérica, no solamente Perú, Latinoamérica.
Voy a conversar con el jefe del Hospital del Niño, que es muy buen amigo mío. Yo creo que por ahí podríamos hacer algo.
Sí. En el futuro, mi sueño es para televisar grand rounds de hospitales en Latinoamérica.
Sí, sería genial, John.
Sí.
Entonces quedamos con ese compromiso. Mira, yo voy a ver esta semana con mi amigo del Hospital de Neoplásicas, que es tumores del cerebro, y con mi amigo del Hospital del Niño, y el próximo domingo lo conversamos, ¿te parece?
Oh, sí, déjame mostrar, sí, claro, cualquiera. Ok, déjame mostrar el Congreso de Latino de San José. Okay. Oh, ok, yo voy a mostrar ahora. Qué bueno, yo he hecho una página. Es mi presentación. Ahora. Ok, aquí está el Congreso de 1 de mayo. Nosotros vamos a televisar en Neurosurgery TV y Neurosurgical en inglés, pero está en español.
Del 1 al 5 de mayo.
Sí, déjame mostrar, sí, ok. Sí, déjame mostrar el programa. Espera.
Mándame el link, por favor, a mi Facebook, y yo lo voy a también publicar de repente en algunos grupos acá de estudiantes y residentes.
Ok, sí, espera un momento, yo quiero hablar de algo, espera. Hold on. No, that's not it. Okay, hold on. Oh. Let's see. Okay, el content. Ajá, aquí está. Déjame mostrar el programa. ¿Tú conoces a Adrian Caceres? Es jefe del mundo, yo creo. Discard, ok. Tal vez tú conoces, Roberto, déjame...
Colombia.
Sí, una ventaja de esto, Sughrue, las personas neurosurgeons residentes no tienen tiempo para un congreso tan...
Mira, John, lo que se me está ocurriendo ahorita es hacerlo como lo están haciendo en Camerún, o sea, organizar una sala grande donde podamos transmitir esto.
Sí, exacto. Yeah. Hacemos esto en Rusia, Italia. Las personas pongan un gran congreso y pongan una pantalla enfrente para participar en este congreso. Ha hecho de Rusia esto en Italia, en África también. Solamente necesito una conexión buena para un cuarto y todos los estudiantes pueden participar.
Ya, mira, escúchame, voy a conversar esta semana con mi amigo del Hospital del Niño, porque el Hospital del Niño, como es instituto, sí, tiene la logística, tiene el ambiente que nos pueda de repente prestar, y como mi amigo es el jefe allá, de repente nos puede facilitar para que ese sea el punto de emisión y otros residentes o neurocirujanos de acá de Lima también puedan ir y participar, porque como te digo, acá nos encanta lo que es gratis. Entonces, si va a ser gratis, yo creo que mucha gente se va a apuntar.
Sí, mira mis pensamientos. Si podemos televisar a todos los hospitales pediátricos de neurocirugía en Latinoamérica, cuartos en cada de los hospitales, para residentes, para venir, salir, porque tú conoces, no puede quedar 3 días, 4 días mirando este congreso de San José. Pero si es un cuarto televisando todo el tiempo, los residentes pueden venir, pueden sentar, pueden salir a rounds, o si tienen una charla muy interesante, ok, Sughrue está hablando a las 3, yo voy a estar al cuarto, ¿entiendes?
Sí, yo.
Sí, ellos necesitan el congreso, pueden participar al congreso.
Por eso te digo, un favor, envíame el...
Pero tú puedes ver el valor, ¿verdad?
Sí. Dame el screen share ahorita de tu pantalla.
Sí, ok, déjame sacar de... Ok.
Para ver qué página es. Y yo ya veo esto y esta semana lo veo en el hospital para ver si nos pueden ayudar. ¿Me puedes mostrar tu pantalla?
Ok, ¿quiero compartir?
Sí, quiero que me compartas tu pantalla.
Okay, go ahead, vaya.
Your screen.
¿Tú quieres yo compartir algo?
No. I want to see your screen to see what is the page of the Congress of Neurosurgery.
Oh, okay. Clanpet, ¿esto?
Ok.
Quiero el link. Ok, déjame mandar el link.
Ya está, ya lo tengo, entonces, con eso lo voy a revisar y lo voy a conversar esta semana en el Hospital del Niño. De repente...
Dice que podemos televisar gratis un cuarto, un auditorio, todo este congreso. Mira el valor de esto.
Sí, por eso digo, lo voy a conversar esta semana y como te digo, de repente apenas tenga una respuesta y si es posible hacerlo, yo te escribo al Facebook para conversarlo, ¿sí?
Ok. Solamente si hacemos con un hospital, yo creo que los 8 hospitales van a mirar, wow, no cuesta plata, los residentes para beneficiar, porque eso puede ir a cada congreso, no tiene tiempo. Pero puedo mirar cualquiera. Tú conoces, cuando tú vas al congreso, tú no vas a ver todos los charlas.
Claro,
tú vas a salir, tú vas a venir, tú vas, ok, yo quiero ver este congreso, es importante, tú vas a estar allá en este cuarto, en este tiempo. El resto, no tenga interés.
Sí, John, entonces lo voy a tratar de ver, como te digo, voy a ver también las horas Y yo el miércoles o jueves te estoy dando una respuesta, te estoy escribiendo.
Ok.
¿Sí?
Ok, yo voy a mandar el link del Congreso de Costa Rica y no estamos haciendo interacción ahora, pero tal vez, porque con Adrian, él piensa yo estoy inteligente, pero no estoy, yo estoy en computadora mucho, entonces yo aprendo con cada médico lo mismo.
No, claro que sí, o sea, nosotros también, o sea, yo por ejemplo no sabía de todo esto porque mi esposa, por ejemplo, utiliza esto del Zoom para algunas reuniones también con sus colegas, pero yo no tenía idea de cuán versátil es.
No, es importante para ti, para encontrar otros neurosanos del mundo.
Y no solo eso, sino
es un futuro.
Es el hecho de que uno puede interactuar, o sea, como estamos haciendo ahorita, ¿no? O sea, tú estás en otra parte del mundo y yo estoy acá y podemos conversar, o sea, porque escuchar una charla por